So I can see from the group there's quite a lot of different professionals. We've got GPs, pharmacists, nurses, and complex regional pain syndrome is quite a complex, debilitating condition, and we've had quite an influx of CRPS patients. It goes kind of through fits and starts. We've got a lot in our service at the moment, and I've been working alongside the kind of hand service more in acute care to kind of reduce or minimise the incidence of CRPS through sort of a CRPS pathway and kind of early recognition of symptoms and early sort of management, so that patients don't, I suppose, become more severe presentations. So this presentation is just to kind of go a bit over that, about CRPS, about the kind of management, early management, and kind of the management down the line in our service and what our service has on offer. Because I'm the kind of lead physiotherapist, I work alongside Steve in the chronic pain service in Highland. So we see patients across the whole of Highland that can be referred to us. So the outline really of the session, I'm not sure if you can see that, is quite small, but it's mainly to kind of discuss what the pathway actually is, because it kind of starts from obviously primary care, from practitioners that will be seeing patients at the early stages, so potentially in plaster room, in orthopaedics, A&E, and GP practices, and what to do and how to identify patients at an early stage that might have CRPS and what to do about it. To understand the signs and symptoms using the kind of Budapest criteria, but we also, there's different kind of apps and stuff like that that can help with diagnostics as well, because it's not something that is necessarily familiar to a lot of people, because in general terms it is a fairly rare condition for the wider population, but we see it more often in our service. Going through a bit more about kind of treatment options, and often kind of the treatment options that we use at the early stages are different to what you would want to try when we come to the pain service. So I thought I would go through what this kind of stuff that we do with them when they come to us, and also at the end I thought it would be useful to give you a bit of an overview of some of the kind of resources that are available for patients with chronic pain, and specifically there's some resources for patients with CRPS. If there's any sort of questions as we go along, if you can pop it in the chat or raise your hand up, don't be shy. I'm quite happy to stop presenting, and we've got plenty of time tonight, so just let me know if there's anything as we go along that you don't understand or you want me to elaborate on. So like Steve said earlier, CRPS is complex. It's changed in its name a number of times over the years. It used to be called various different kind of definitions, but at the moment we're kind of using the term complex regional pain syndrome. It's complex in the nature that I suppose the pathology of it is, not fully understood. The pathology kind of involves the central nervous system, the peripheral nervous system, particularly the autonomic nervous system. But also there's thoughts that it can involve the immune system as well. So some of the treatments with CRPS, there's some services that use sort of like infusions and stuff like that with biophosphates for the kind of immune system. So CRPS is quite a difficult condition to have to live with. So it is desirable to try and get these symptoms of CRPS diagnosed early on. It's most common after an injury to the wrist. So the most common reason for developing CRPS is usually from a fractured radius. It can be anywhere from quite a simple fracture to a more complex. There is some evidence that the more complex the fracture is, it can make you more susceptible to leading to CRPS, but the more kind of simple fractures can still develop it as well. In some places it can be anywhere up to 25% of wrist fractures can develop CRPS. And we went through a phase in Rigmore, because I previously worked as an MSK physio and worked in kind of intensive orthopaedics a few years ago. And we had a spell of a massive spike of patients with CRPS, and it probably was hitting about 10 to 20% of patients. It was felt there was a number of reasons for that, lack of understanding from staff. Patients were coming in when their plasters were too tight. It wasn't getting picked up on. Positioning of the plasters as well, which I'll go into later on. But usually if patients are presenting with CRPS, it will usually be quite early on after they've had trauma or immobilisation, but they can develop CRPS from an atraumatic source. Trauma is much more common, but you do get cases where they haven't had any trauma whatsoever, and it's usually kind of separated into kind of type 1 and type 2, depending if they have nerve compromise or not. A lot of the evidence shows that a lot of the issues surrounding CRPS is to do with the early changes that happen in the brain. So I think a lot of people perceive that it's a lot to do with what's happening in the periphery, which is more obvious, the changes with their nails. So their nails may change in terms of the thickness, brittle nails. As you've seen in the first photograph, changes in their colour of their skin. Their skin might become more shiny, mottly, their skin colour as well. So these are all the kind of vasomotor, pseudomotor temperature changes. But a lot of these symptoms can be indicative of other things. So the Budapest criteria is really useful to kind of think about, is this CRPS or is this something else that's going on? Because if it is related to trauma, is considering other things like, is there an infection going on? Is there something else that's predisposing them to the symptoms? So it's looking at all the kind of signs and symptoms and piecing it together. But the amplification, there's a video that I'll play for you later, the kind of changes that happen quite early in the brain, they think that potentially are why patients may become quite chronic and their symptoms aren't improving. So some of the kind of rehabilitation is to do with brain sort of training. Some of it is to do with visual, looking at their limb, touching their limb, to try and kind of reduce that amplification that happens in the brain, and some peripheral work as well if there's sensitization in the limb itself. The other thing to mention, the patients that we see that tend to do have more severe cases of CRPS, they tend to often have a history of trauma and mental illness. And again, if you link that into thinking that it potentially has started from that early changes that happen in the brain, if they have that history of trauma, mental illness, and that threat-based system in their nervous system anyway, add CRPS into the equation. These patients, not always, but generally speaking, when we have the severe cases, the ones that are suicidal and at the point where they describe that they want their limb to be amputated, the more severe cases, they tend to have usually a history of some sort of trauma. And it's not that the illness itself is a psychological illness, it's more that the fact that they've got trauma amplifies their nervous system, and then CRPS is more apparent. So these patients usually need more intensive input to improve. But saying that, CRPS can vary from person to person. So some patients, if you catch them very early, their symptoms can be very, very severe. But if you get the right treatment in very early, they can improve and the condition can resolve itself. So there's a lot of hope that a lot can be done, and there's lots of resources. So this is just a picture. This was taken from the Liverpool pathway. So they're looking at, in their service, the positioning of their plasters. So the top one is someone that's got a good positioning of their plaster in a neutral wrist position. One kind of warning sign of somebody that could get CRPS is if their plaster restricts their wrist into a flex position. And they're thinking again that's to do with kind of vascular compromise and to do with the kind of median nerve and the radial nerve compression. So a patient in the bottom picture might be much more likely to develop CRPS because of the flex position of their wrist, and also with the wrist being flexed, they don't have as much range of movement in their finger and thumb. The key part is to make sure that their their plaster's in a good position, it isn't too tight, the patients are not saying that they're claustrophobic in their cast, that they've got a good active range of movement in the plaster. So if you see someone that's got a plaster that doesn't allow them good movement of their fingers and thumb, that might be a bit of a warning sign. So so this slide just kind of goes through the kind of risk factors for CRPS, to kind of be thinking in your head if someone's coming to you after potentially acute trauma, but it could, like I said earlier, it can be atraumatic. Tends to affect the extremities, so most common in the hand and wrist, but we also see it in ankles and feet. Sometimes what happens sort of not just after kind of fractures, but soft tissue injuries. So I've seen a lady fairly recently, middle-aged lady, who decided to take up kind of running to try and lose weight. So she was doing a bit of running, developed almost like an acute calf injury, you know, the swelling, bruising. So it had started off as a calf injury and then had developed into a CRPS type pattern. And I'd wondered if it was to do with the kind of bleeding and the vascular kind of compromise, and that potentially might have kicked it off, similar to, you know, having a restrictive plaster on. And there is a few patients that we've got that have developed it after, like, Achilles problems, being in plaster after multiple surgeries and things like that. So yeah, multiple plaster changes, neglect of the limb. So if patients are coming in and they're coming into your clinic room and they look like they're not using that arm, they're holding it very kind of stiff. If they push the door as you come into the clinic room and they're not using that limb to catch the door, or they're not using it to express themselves, the arm is kind of dangling, almost like someone with a stroke. And also that expression of anger towards the limb. Patients will often sort of say that they're really hacked off about their arm or their leg, and they feel, you know, some patients will describe things like they feel like the limb is alien to their body, and this is normally termed under what we call body disturbance. So there is a body disturbance sort of index of questions that you can ask the patient if you're thinking that there's potentially more of that central component, that sort of changes in their brain, sort of feeling that the limb is bigger. So this lady that I spoke about earlier, who had the calf injury, she described her leg to feel like an elephant. So she said her leg felt the size of an elephant's leg. And at the time I was actually speaking to her on the phone, so I couldn't actually appreciate, you know, if this was the case or not, until I got her in, seen her face to face, and visually the limb looked exactly the same size. We measured it, there was no difference in size, but to her the leg felt and looked like an elephant's leg. So there's that appreciation of their limb feels not only extremely painful, but it feels massive, bigger, disproportionate to what is actually visually seen. Another rule of thumb is if their pain is uncontrolled after a couple of weeks. So if they've had, say, a soft tissue injury or a fracture or a minor sort of injury, if their pain is still persistently being poorly controlled after 2 weeks, and they've been given simple analgesia, and their pain is still sitting at more than 5 or 6, that would be an early warning sign of, is this the early sort of signs of CRPS? Is the pain disproportionate to the injury? Their pain should be settling by now. Have they got restricted movement? The difficulty is, like, a lot of the signs and symptoms of CRPS can be similar to other things. You know, if you're in a cast, your fingers get swollen, they get stiff, they get discoloured with changes in your vascular system. So sometimes it can just be that their cast was a wee bit tight and they haven't moved their fingers enough while they've been in cast, and it isn't actually CRPS. So it's important not to label the patient with that unless they really fit the criteria, and choose your words kind of with care, because it can be a difficult one. So this is the Budapest criteria. So this is the kind of gold standard for diagnosing patients with CRPS. And the main one really at the top there, you can probably see, is that the patient has continuing severe pain which is disproportionate to the event. So, you know, depending on the injury, you know, if it's a really severe injury, you might expect them to have ongoing severe pain. But you would still expect with the right treatment and the right analgesia that trend to be coming down. But alongside that, they would have to have at least one or two of the other signs and symptoms. So the Budapest criteria say that the patient has to have at least one sign, a sign being something that, as a clinician, that you can see as a problem, and then a symptom being what the patient reports. So they split it up into the 4 categories of sensory. So sensory being sort of allodynia, so it could be to light touch or it could be to temperature. So that feeling of, they'll say to you, I'm lying in bed, I can't bear the sheets being on me. I've got a patient at the moment that even in the winter when it's freezing, she comes in with a short-sleeved vest because she can't wear long-sleeved clothing because it's just so uncomfortable. It feels tight, restrictive, and agonizing pain. Another lady that I'm seeing for temperature, she has to wrap up with lots and lots of layers, especially in the winter. So the cold weather really is a trigger for her. And yeah, so temperature regulation and temperature being a very sort of a big trigger can be a sign of CRPS. So the vasomotor is physical differences in temperature. So when you examine the patient, you can feel a difference in temperature between the left and the right limb. And skin changes, asymmetry. So again, the colour, shininess, trophic changes, so looking at their fingernails, excess hair growth, all of these things, sweating. So you're looking at the autonomic nervous system there. And alongside that, you're looking at motor changes. So a lot of the patients will have significant reduction in function. They might even have contractures of their fingers or their ankle or their limb. Distortion in the way that they use their limb, their coordination, they're able to coordinate their limb. Again, that comes down to the kind of central kind of changes that happen with the disease. So what do we do with them? I'm just going to see if I can just get the remote to put this back on. 2 seconds. Sorry, I've had 2 screens up and my screen's kind of just switched off, so just bear with me. Okay, so that's come back up. So in NHS Highland, because of the problems with the incidence of CRPS, we developed a CRPS NHS Highland pathway, and we're going to be putting it up on TAMS quite soon once we get agreement from the rest of the team. So the bit in red is just examples. It's probably quite small for you to see actually. Examples of kind of signs and symptoms, like I spoke about earlier about early recognition of the symptoms, about the pain and the sweating and the trophic changes. But also it links into a diagnostic pathway, so it gives you ideas on what else could it be. CRPS can be an option, but have you considered X, Y, and Z? Have you considered it could be an infection? Have you considered, this, and this? And then the kind of final tick off is, yes, I do think it is CRPS. It does fit with the Budapest criteria. So the first kind of line management really would be sort of getting their pain under control. And I'll talk about that later, about kind of options. And that can be obviously pain management skills, which again I'll talk about later, or mostly in the early first line treatment would be kind of analgesics. Again, I'll talk about it later, but with CRPS, there isn't any licensed medicines for CRPS, but there is evidence to use first-line drugs, neuropathic, using the neuropathic guidelines, and we'll talk through first-line and second-line drugs later in the talk. And a lot of it is reassurance. If the patient comes in, they're not using their limb, they're not moving their fingers, they're neglecting their arm, they're not looking at it, they're not touching it. A lot of it is re-educating that so that they don't have that fear of using their limb, because the more that they avoid using it, the more they'll get into fear avoidance behaviours, and there'll be more amplification from the brain and the central nervous system, and they're unlikely to improve. But again, it's getting that balance, and you'll see that in the video that'll hopefully it'll work if I play it later, is getting that balance, because what you don't want to do is you know, really push the patients to do lots of physio and lots of movement, and then you exacerbate their pain because that movement has caused a painful response, and then it amplifies the pain even more. So there is the fine line with CRPS. You know, you don't want to hammer them with lots of physiotherapy if it's exacerbating their pain. So it's very much patient dependent on how they respond. So starting off really small, building it up, and that kind of fits in with some of the graded motor imagery that we use for patients. So that goes anywhere from just thinking about movement to actually doing movement with the patient. So the thinking about the movement might be for patients that have got really severe pain, they're not getting their pain under control with analgesics, you're really struggling with them. Active movements really exacerbates their pain. So a lot of the evidence is that you have to start with you know, the kind of premotor activation from the brain. So we know that just thinking about movement can generate pain. So sometimes with CRPS, we do have to take it right back and get them to imagine different movements, thinking about gripping and grasping, and doing things like left and right discrimination, looking at images, for example, of limbs and having to decide whether they think it's a left limb or a right limb. And a lot of that's to do with the cortical changes that happen on the brain, the mapping changes that happen when they have CRPS, is that mapping process, that sensory homunculus that you might remember, becomes amplified and different. And this is why, you know, maybe this lady with the elephant leg felt her leg was bigger, and it was because of the mapping and the cortical changes. So with her, we had to do a lot of that, looking in the mirror, touching her leg, getting lots of that sensory input. She actually took photographs, which she really despised, but she had to take photographs of her limb in different positions, and it was on her phone, and she had to regularly kind of look at these pictures, recognise the size of her limb, touching it. So it's all these kind of things that we do. So the boxes there as part of the pathway is to guide clinicians, particularly physiotherapists. It's quite physio heavy in terms of the kind of stuff that we would expect clinicians to do with patients to help dampen down their symptoms. So some of it's sensory work, some of it's, you know, if they're really hypersensitive and have allodynia, there's a desensitization program that we use, different fabrics. So we start with light touch and work through different materials to desensitize their skin and their nervous system. And you know, there's a process of that. If that's too much, you can work on the other side if they're too sensitive. For the vasomotor, we do things like contrast baths. If they're really sensitive to temperature, you can start with regulating their temperature by using things like basins of water with warm water to begin with, if they're able to tolerate that, and then making the water gradually colder so that they can tolerate going out in cold weather, that they're not just avoiding doing these things, and that their system regulates and becomes used to that. And then moving down, there's sort of just your what we talked about, the graded motor imagery, doing active functional movement, goal setting, pain management skills, but very much trying to do that locally and alongside the rehab, making sure the patient is on adequate analgesia, because a lot of patients, you know, the physio has to be fairly aggressive to get their limb moving and get them touching their limb, and sometimes it can generate them feeling kind of almost a bit sicky with doing these things. So making sure that their pain's under control with analgesics first, because often physio can be very difficult to do if the patient's pain isn't under control. With the pathway, then the next step is to reassess after a couple of weeks, and if they're having quite regular physio and they've been trialed on the first line analgesics and they're not improving, the kind of second line management in Highland, if it's an upper limb, is to liaise with the hand therapy service. So the hand therapy service is composed of two very specialist hand physiotherapists and an OT and a hand surgeon, and they would be willing to see the patient as a second opinion. A lot of these patients are in their orthopedic clinics anyway, because a lot of them are post-trauma. But if they're not, you can contact them directly and ask them to see them for an opinion, or it might just be like an email correspondence to say, you know, I've tried this, this, and this. Is there anything else that you'd be able to offer? And they might be able to, if the patient can travel, they might be able to see them, or they do offer near me consultations as well. It's a bit trickier with hands on near me. So that's like a mini sort of MDT approach, and that's the kind of middle management. However, we do want to see them in the pain service if they're not improving. There's a lot of evidence that getting patients earlier in the journey into the pain clinic, because we know there's a lot of psychological distress associated with CRPS, we have access to that in the pain service. So if they get that kind of second line management, they're still not improving, they're still presenting with moderate to severe CRPS, they've got yellow flags, it might be handy to score their mental health, or decide if you think that their mental health is affected, looking at their anxiety and depression levels. And that body perception thing is a big thing as well. If you're noticing they're neglecting their limb, they're saying that they want to amputate their limb, they're feeling that their limb is totally alien from their body, they're becoming more and more kind of socially isolated, not leaving the house, becoming more and more distressed, definitely consider referring to the pain service. So when they get referred to the pain service, even though we do have long waiting lists, CRPS patients will be prioritised. So they will be prioritised as an urgent patient, and usually they will see me first. So they'll see me face to face, and then from there we'll make a decision whether the rest of the team do need to be involved if there is a lot of sort of psychological problems. Then I will ask my colleague Lauren, who will see them. We haven't had psychology input in our service for a while, so she's got quite a big backlog of these patients that have been waiting for psychology, so there is a little bit of a wait. And oh, this is the video. Is there any questions in regards to the pathway, in regards to, you know, first of all, kind of diagnosing and kind of recognizing the symptoms, but also at what points to sort of think about moving to the next phase and escalation and referral? Is there any questions at all? No, silence. Everyone's happy with that. I'll go into a bit more detail about the medication, and Steve can maybe chip in as well about medication choices for patients with CRPS. I'm going to attempt to play this video. It didn't work earlier, so I'm keeping my fingers crossed it's gonna work.
Nicola, did you mean the feet are more difficult to do on near me or hands?
No, I did mean hands.
Yeah.
Yeah, I think just like with physio in general, like there's some stuff you can do on the phone, but with hands, as a physio, you really want to feel their hand and feel the movement. And I think the hand therapists have found that quite hard on near me. With hands, I tend to always get them in just because you can see how they're using their thumb and stuff like that. I think it's difficult to see them on the screen of what they're actually doing, if they're using the right joints, if they're bending from their FCPs, or whether they're bending from their knuckles or not. But yeah, feet would be impossible to do as well. Right. Just going to stop presenting that. Steve, can you give me the thumbs up? Can you see that? Yeah, okay. So I'm going to play it. I'm hoping you're going to get some sound. So this is a video that helps explain the kind of changes that happen in chronic pain in the brain, but particularly with CRPS.
It can be hard to explain brain function, neuroplasticity, and the changes that happen in the brain in pain.
Steve, can you hear that?
Yeah.
Yeah, okay, I'll carry on then.
And it's not an easy thing to tell somebody that pain is made in the brain. It's all a bit abstract. You can't see brain function. It's in 3D. But explaining pain and explaining the role of the brain in pain is a critical part of the Explain Pain work. These nail boxes may help. We all had one of these in the 70s. They're still around, easy to find, and they may well be making a comeback. Normally, we know our hands well. There's a lot of territory in the brain representing, looking after each hand. We can move each finger independently. We know where our hands and fingers are in space. You know when each finger is being touched, and we can do remarkable things with our hands. We could write, sculpt, play musical instruments, and talk. Let's say that each of these nails represents 1 million cells in the brain. And these will be cells that have neural and immune functions, and they work very closely together. We know our hands in the brain because these cells here, representing each finger, at a particular time and place can be turned on, and these ones in between turned off. The science term is inhibition. We also know that it changes dramatically. For example, if you have 2 fingers held together with a bit of tape, they will join up in the brain. Essentially, they become sticky. But within a few hours, with normal movement, this will reverse. Talk about use it or lose it, there's a lot of that in the brain. In pain, things are a little bit different. We know things can change dramatically. Let's say that the person's index and middle finger is in trouble, maybe in pain, not being used, frightened to move. What can happen if the brain makes the conclusion that more protection is needed? It can call upon neighbouring cells, neighbouring immune and neural neighbourhoods of cells, and pull them in to the territory looking after the fingers. So we call this smudging, or the science term is it becomes disinhibited. This remarkable defence might be helpful in the short term, much in the long term. In the long term, you might not be able to recognise the difference between 2 fingers. It might feel a little bit different, not yours, a bit bigger, a bit smaller, perhaps. And you may start to see changes in activities, particularly high-level activities like playing a musical instrument, writing, doing up a button. These plasticity changes, of course, are not just confined to the hand. This can happen anywhere in the body. This sounds bad, but it's happening all the time. It happens in all of us. It's a very useful defence. The aim should be to get to know the hand again, to love the hand again, to re-embody the hand again. In a science sense, to take away or inhibit these cells in the middle which are joined on and become sticky with the original fingers. There's 3 main ways in which you do this. Principally is education. If you can take away usually the fear that made the brain construct this defence, that would be number 1. Secondly, graded exposure, graded activity, which could range from thinking about movement to actually moving. And thirdly, taking the hand out into different contexts, feeling different surfaces, feeling different places, exploring with the hand in space. So here we have a very simple addition to the media of teaching. And one of the really good things about it is someone can actually do it themselves and feel what is going on. It actually feels quite nice too. Have a go yourself.
Any thoughts on that video, did you think?
I think our body image can be quite a lot more plastic than we think. You know, as a great example is if you learn to play tennis, then you know where the end of the racket is in relation to the ball, and so your brain adapts to make your arm longer with a big racket on the end of it. If you there's some great experiments looking at distortion of body images with virtual reality and using illusion of stretching a finger. Have you seen that? It seemed to have really amazing effects on hand pain. Yeah, so it's really interesting field.
Yeah, I mean, they use quite a lot of the stuff. I used to work for Sport Scotland with kind of elite athletes, so they do that kind of thing to make, you know, how David Butler was talking there about provision. So you know, to make yourself more accurate and more precise at your sport, it's that kind of practice and preparation mentally about, you know, say you're a rugby player, you know, mentally preparing yourself to take a penalty, so you've got that pre-motor. So a lot of the stuff that we're doing with patients, especially the more severe ones that you can't do the active movements and you're doing more of the thinking, it can be quite difficult to explain it to a patient. You know, why am I looking at limbs? Why am I looking at images? Why am I thinking about movements? It's that kind of explanation of, you know, that kind of changes that happen in the brain, and you're wanting to kind of dampen down, like the David Butler was speaking about with the pin board. You're trying to switch off the unwanted pathways that have formed, and this is why the patients that have severe pain, they have amplification of the size of their limb and stuff like that. So is there any more thoughts before I move on to the guidelines? Does anyone have any patients or anything like that that this rings any bells with, that they've seen? So this is the complex regional pain guidelines, and it's kind of mainly having kind of 4 pillars of kind of practice. So what to do with these patients. So some of it's sort of keeping the patient in the centre, kind of getting the patient under correct medication, pain relief, physical therapy and vocational therapy, and psychological therapies, and patient information and reassurance. And I think that's the key bit, really. You know, if they've got this amplification of their symptoms because they're really worried, they're neglecting their limb, they're fearful, they don't know what's going on, they haven't got a diagnosis, they're worried something sinister's happening, that sort of reassurance and that kind of guidance to start using their limb and educating them on what's going on can really be powerful to help dampen down those pathways that form, and that volume thing that we spoke about a few weeks ago with the nervous system, that imaginary sort of volume, like a radio gets turned up, everything becomes amplified. So the more that the patient understands about their condition and how they can help themselves, the more that volume can be turned down, and the more these terrible symptoms that CRPS poses can reduce, would be the theory. So there's lots of things that can be done for CRPS, and this is kind of just going over some of the things we've already said. Early recognition, getting the patient under the right education and reassurance, getting the patient under using medication. There's no licensed medication for CRPS, but in a couple of slides on, we'll talk about the neuropathic formulae in NHS Highland. Often a lot of the medications are ineffective in severe cases, and you can see why if it's more to do with the cortical changes and the changes within the central nervous system. We know that in often with chronic pain, medication has its benefits, but it has its limitations as well. And sometimes by the time CRPS patients come to our service, they're often on a bucket load of medication. So one of the important things is to stop ineffective medication as soon as you can. So if they're on medication and it's not helping their pain, then just take them off it. It's more unhelpful for them to have CRPS plus medication side effects. So hopefully the analgesic side of things is more to facilitate function and allow them to be able to do the physio and recover and get their limb moving, and then reducing that. The important thing is that I spoke about this earlier, is finding that happy medium. Feed avoidance and inactivity can make the condition worse, but overactivity and forcing patients to keep moving their hand can make it worse as well, because it's the system sees it as a threat. So there have been times where clinicians have maybe over intensified the therapy because they can see the person can't move their fingers, or they can't, weight bear, and they've really pushed the physio, for example, and the patient actually in turn has ended up worse because their system has then kicked that in as a threat. It's then increased their pain, and they become in a vicious circle. So it's very much a fine line of getting their limb moving, getting them touching it, getting them looking at it, getting them acknowledging it as part of their body, but not overdoing it. And every patient's different. Some patients will tolerate quite intensive therapy, whereas other patients won't. And again, it's looking at what level to start them off at. With the patients that we see, it is often thinking about movements, that pre-motor stuff. We have cards, so we have therapy cards where we have cards with lots of hands on them, different distortions, different pictures of them upside down and round different ways. And the kind of pre-motor stuff would be sending them away with these cards, getting them to look at pictures of hands or feet, depending on which body part it is, looking at magazines, getting them to turn magazines over. If they see people in the street, getting them to look at their limbs, to look at, is that a left limb, is it a right limb, what would it feel like to grip a cup, if that's, for example, the problem that they're having. So some of it can be, well before actually moving their limb if they're really severe, and it's about acknowledging that. But that's some of the stuff that we're trying to work on with CRPS, is increasing the knowledge base of some of these techniques so that people can do it locally, because normally you have to do it in person with the patient, and a lot of our patients live miles away from us. So we're doing these sessions to try and see if there's people interested out in the communities to upskill in some of these techniques, and I'm happy to do that with people individually if they want that. And early OT as well. There's an OT that works at Rigmore that specialises in CRPS, that is happy to do desensitization work, functional work, particularly with upper limbs, but she will see lower limbs as well, in terms of stuff that they're struggling to do, but she'll do a desensitization program as well with them. The key thing is to collaborate between primary and secondary care with these patients, because they have so many difficulties with different areas of their life. It's about making sure that we're all on the same page and all telling the patient the same thing, because it can be very sort of confusing if patients, for example, if they go to orthopedics and orthopedics tell them one thing, and then they go to their GP, and then they come to the pain service, and then they get told they've got CRPS, and sometimes it can be quite a disjointed journey for the patient. So we do really want to try and improve that. So we're using posters in orthopedics and in plaster rooms to kind of help clinicians and patients to identify early signs of it, so that patients can be put on the right pathway for treatment. So this is just some further treatment. Again, it's all based on the individual need of the patient. So this is just some more examples of things. So it's looking at the changes can be, sorry, I never meant to change that slide. The changes can be peripheral, so can have problems with their kind of soft tissues, stiffness in their fingers, contractures. So the treatment you might do might be specifically targeted to their periphery. Obviously, we know that cortical changes happen quite early for a lot of CRPS patients. So it is looking at doing treatment for that. So lots of proprioceptive work, motor planning, coordination, trying to use the limb, looking in the mirror, accepting the size of the limb, touching it, and sensory work as well. So yeah, it's all sort of based on the individual, based on what their main problems are. So we've talked about that. And sort of the more general patient skills sort of we use, which can be sort of delivered anywhere. It doesn't have to be delivered in a pain service. So things like pacing. With CRPS, the pain is normally very severe, but patients will sometimes push themselves and overdo things. Or they might do the opposite. They might underdo things and avoid using the limb because they're scared of making it worse. So it's about sort of educating the patient, getting that happy medium. Sometimes we'll use things like pacing charts or goal setting to try and set up some functional goals of things that are realistic. We don't want setting up goals that are beyond what they probably realistically should be doing, because again, looking back to the video, we don't want to amplify their pain by adding in another threat that will increase the sensitivity of the nervous system and make their pain worse. So there's lots of different skills that that you can use out in primary care and out in third sector, and obviously these are some of the things that we do when we're running individual work with patients, but also on pain management programs. From a psychological point of view, patients also have access to online CBT resources. As a rule, the patients that we see with CRPS, that they tend to have more complex needs, and the online CBT sometimes isn't enough. They often will need to see the psychologist within our service, because the condition can often be quite a distressing condition to live with. Often the patients are, have quite a lot of suicidal ideation. So it's bearing that in mind. Whether if you've got someone, whether you've got any local mental health resources that you can support the patient with. So this is now moving on to the medication side of things. So again, there's no, as I mentioned earlier, there's no sort of licensed drug specifically for CRPS. We do have a neuropathic formulae that was, it's a bit outdated. It hasn't been updated in a couple of years. That's on TAMS. So it's what Steve talked about a couple of sessions ago about neuropathic pain. So what the guidance is for CRPS is to follow the neuropathic formulae. So offering a choice of the first line treatment. The first line treatment for neuropathic pain is Capacin cream, but that would be quite inflammatory for somebody with CRPS. Putting on cream to their sore area, it can often make it worse. So normally amitriptyline orally would be first line / nortriptyline if amitriptyline was too sedating. And then you've obviously got all the other second and third line drugs, sort of duloxetine, gabapentin or pregabalin. Sometimes when they come to the pain service, they will get dual therapy, which can be quite problematic because of the side effects. So we would, we try and avoid that. But some of the more severe cases, so what I mean by dual therapy would be they might be on an antidepressant and anticonvulsant. So they might be on pregabalin and amitriptyline if their pain's really bad. But the two together, the side effects can sometimes outweigh the benefit. If the treatment is not tolerated and you've gone through the drugs, sometimes considering sort of opioids, tramadol, if needed, but for a short period of time. Again, we know that medicines can have a limited benefit in chronic pain, but because it's such a disabling condition, and if they're really struggling with function, there is some evidence to use mild to moderate opioids in the short term to allow function. But again, making sure de-escalation of these medicines if they're not working and they're giving more side effects than not. Yeah. So in terms of the medication, Steve, have you got anything else to add to that?
I think the other thing that there's some evidence for is using alendronate in the early stages when they're starting to get sensitivity, and I think it's 30 milligrams, but I'll double check that
Okay.
and send a bit about that. And then the other thing that's been used, not so much in the UK, is high doses of steroids at the early stage. So in Germany, they're very keen on that. But with all of these things, because it's quite a rare condition and quite variable in patients, I think it's really difficult to get good evidence for things.
Yeah.
And so the Royal College of Physicians guidelines that were actually coordinated by a pain specialist in Liverpool, they're quite confusing. Really, there's bits of everything that you can try. So I think one of the main things is if you can get the patient moving, it's got the strongest evidence for it in terms of getting if the hand. You were talking about the previous names for it. Originally, it was called causalgia by Silas Weir Mitchell in the American Civil War. He saw soldiers with this, and then reflex sympathetic dystrophy. And it's only more recently they've renamed it complex regional pain syndrome. But if you're always guarding the limb, then eventually the muscles atrophy and the joints become really stiff, and it's too painful to cut the nails, and so you get the sort of atrophy of the hand or the foot. I haven't seen many patients like that, luckily.
Yeah. So I thought I would put up some other bits of stuff that we offer in the pain service. So as I mentioned earlier, we do sort of pain management programs, individual work, physio and psychology, medication. We'll review the medicines to make sure the medicines are appropriate. For some people, we do IV lidocaine infusions. We do them in Golspie, and I believe, Steve, you started doing them as well in your area. I know that some places
Not
do.
if I can help it.
Not if you can help it, no. It works for some patients. We also there's the lady that with the calf injury, she ended up having a lumbar sympathetic block, and that actually really helped her pain. So sometimes with the lower limbs, Dr. McLeod will do a sympathetic block injection, and if it's earlier in the journey, certainly she had a good response, but I've had other patients that hasn't worked with. Again, the evidence base is probably quite poor. Stellate ganglion block is a sort of similar idea for the upper limb and the neck. Again, it's very high risk, so very rarely used, but I think it has been done in the past successfully. But yeah, and the National Pain Management Programme is a pain management programme in Glasgow that has a higher intensity and psychological input. So some of our CRPS patients would go there. And then the last slide is just to give you more information on what to signpost patients to. So Burning Nights is a CRPS website that was written by a patient with CRPS, but it's got quite a lot of useful information on the condition, and you can reach out and communicate through that as well with people that have got CRPS. There's obviously local stuff, Legowit, they run self-management support groups. Pain Association, again, they have pain management groups, but they also have lots of kind of videos to help with managing the different aspects of living with pain. So there's lots of different sort of resources out there. There's a really good webinar if you've got staff that are in your primary care practices that you want to upskill in chronic pain. We've got a new TURAS module that I developed for NHS Highland that you can put your staff on to upskill on. There's a CRPS app that it basically asks clinician questions. You know, does the patient have pain that's unrelenting? and it asks you questions about the sensory and the vasal, and it asks you questions to exclude other conditions, and then it comes down at the end and it'll say this person sounds like they could have CRPS, or it's unlikely that this person's got CRPS. So it's a bit of a helping hand. Like Steve said, it's quite a rare condition, so clinicians might not be confident with remembering what all the signs and symptoms are. And the PPA, which is the Physiotherapy Pain Association, they have a brilliant webinar. It is a long webinar, it's an hour and a half, but it's really, really thorough on the guidelines and the treatment and how to perform the treatment and what people do across different areas in Scotland. So I would definitely recommend that for clinicians. And that's it really. I've done quite a lot of training sessions individually for clinicians that want to upskill in CRPS rehab, because it is quite a complex condition to manage and patients are often very distressed. So if anyone wants to reach out to me and wants any more additional training, I'm happy to do that. Stop presenting. Does anyone have any sort of questions about that? It was quite a long time to have to listen to me speaking for.
Very
silent tonight.
In an uninteractive audience today. Yeah. We need to get some sort of remote stimulation devices that it can give people a shock unless they say something. Tina, you were going to say something, but you're muted.
Sorry, it comes and goes. Can you hear me now?
Yes.
Yeah, that's better. Yeah.
I hope you don't mind if I have a comment. The one thing that I think you said that fear can amplify the symptoms and the pain. And one of the things that I see missing a lot from the presentations is the word hope. Now, I'm sure you all, in your attitude and information that you give to patients, give them hope, but the word hope isn't mentioned very much or even said. And one of the things for me as a patient is that I lost all hope. And nobody used that word or helped me to see a future without pain. So when we talk about pain management, to me, that wasn't very hopeful. And even if I think about it now, it still isn't hopeful because it means I've still got to have my pain. Although I've received the benefit of pain management and I know there is hope. And I wonder if this fear that people have and the hate perhaps they have of their limb, in a way the hope is being able to befriend their limb or their hand in order to work with it. So when I had to accept my pain, I was then, and what I do is to see it as a friend. It's almost like, oh, hello, here we go again. What are we going to do with you today? That sort of thing, rather than want to get rid of it. Because I can remember saying to my husband, I just want to be filleted. I just wanted to get rid of my spine. I hated it so much. Take it out, throw it away. I don't want it. It's too painful. But working with patients is about, how do you work with something that you hate so much? You have to learn to befriend it, and you can't do that without hope. And I think that goes across the board for chronic pain. But when you were talking about a hand, I visualize people going, "Hello, hand," rather than take it away or take it off. It's a way of working with your mind and your brain as a challenge there. So sorry, that's all I wanted to say. It's hope is quite a big thing.
That's very much the point of the Recognise online app, and it's really interesting to look at. There's some videos that David Butler's done about that, and mirror therapy as well. Is that you've got this part which is always painful, and you're always trying to protect it, and so you develop that dislike and alienation of it. And so I often ask patients, what do you think about the way it looks? And have you had times where you felt you didn't like the part? And I think if you've got that dislike, then I think there's a wee bit of evidence that doing the right-left discrimination with recognised is actually more likely to be effective. So yeah, we do give some hope to patients, I think, and where it becomes hopeless, then yeah, you can have really terrible outcomes. But I think we've come a wee bit after 6 o'clock, and thanks very much, Nicola. It was a great presentation, really comprehensive.